Hey, everyone, welcome to House Healthcare. It's the afternoon session, and we have the Social Work Compact on tap to review today. First, though, I just want to do a quick catch up with the committee since we haven't actually met as a committee today. So we have a couple of people that have other commitments that will be coming in and out. We do need to make sure that we always have six. So if you're the sixth person and you need to leave, let's just flag that for me so we can keep moving on. The other thing, we're working on next week's schedule, so it will be posted when it's done. It's going to be mostly budget adjustment. So we'll have, DEVA, DMH, the various agencies in to focus on budget adjustment, not, other topics that we have with them at this point. So, and it will be a pretty packed week. So I'm just giving you all notice now. I had hoped, that we could get out a little bit early Friday because the rest of the week's going to be packed, but the BAA is under a really tight timeline. So Wednesday, we're starting at 8:30, the joint testimony with health and welfare. So you'll see all this on the agenda, but I just wanted to put it out there to make sure you look at the times to make sure you're all good.
Appreciate that. Thank you.
Yeah.
Getting it in my calendar right now.
All right. So with that, we are going to hear from the sponsor of H543, which is a social work licensure compact.
So I'm Representative Brian Chino, for the record, and I'm testifying on H543, a bill related to social work, interstate compact. I don't know if that's the exact title, but that's why Ledge Council's going next. So I will reserve the walkthrough for our professional lawyer, and maybe just speak for a minute, not about interstate compacts, because this committee is fully aware at this point of what interstate compacts are, because we've passed many bills in the last year creating them, but specifically about the benefits of a social worker interstate compact. And I say this as a licensed clinical social worker. And I do want to highlight the significance that in the profession of social work, one of our key roles is advocacy for others, which many of you may have seen me doing here. But the ultimate advocacy is when we can empower a person to speak up for themselves. And so there is great significance for social workers to be able to witness a social worker leading the effort to create a social work compact. So I want to acknowledge that. And some of the unique aspects of the profession of social work involve a deep understanding of the power relationships, the person in the environment perspective, the idea that human behavior shapes the physical and social environment, and the physical and social environment shapes human behavior, and with that awareness and with that understanding, we can empower people to adapt to their environment, but not only that, to also change their environment so that makes things better for themselves and others. Social workers have provided a tremendous amount of service during the pandemic, but we've faced many barriers along the way due to licensing issues across state lines. And there were emergency licenses that were allowed during the pandemic that are no longer allowed. And it really, I was able to get a license in Maine, like immediately, to see someone there. But now if I wanted to get that license, it would be a more complicated process. And I'll let other social workers speak to those details. Last but not least, I would just say about our profession, something else that makes us unique is that we are trained to work on many levels, from the micro to the mezzo to the macro. So that means that in our social work training, it starts with working with individuals, the one-on-one relationships, but we also receive training working with groups. So how to facilitate groups and lead groups, and we learn about group dynamics. We also study family systems, and we learn how to work with families. But then at the higher level, the macro level, we receive training in organizational, practices, and we learn how to work on an organizational and community level. And so as a social worker, I have been able to practice one-on-one with people in therapy, for example. That's an example of like individual work. The group work would be like maybe leading groups for youth who are justice involved and learning skills to prevent further involvement in the justice system. Family level, doing I've worked doing family counseling and family therapy with reuniting children with their families who were placed in DCF custody, for example. On an organizational level, I've been a supervisor in agencies where we developed alternative behavior management strategies that shifted from using force to get youth to comply to creating using restorative practices. For example, turning the planning room into the solution zone. And so that's organizational social work. And on a community level, organizing with my neighbors to create Isham Street Gardening and Other Optimistic Doings, which is a community group that gardens in the neighborhood, and through gardening we reduced crime rates. And even in this current time where violent crime is up 30 to 60%, crime is up, violent crime is up 30 to 60% in some places, that our street, I don't want to jinx us, but our street still has lower crime rates than the entire neighborhood, even though all of the rates have gone up. And so I think that's an example of community level social work. So I just share that with you because one of the unique aspects of the social work profession is we do receive training in how to do the work on all those levels. And not all social workers get the chance to do it on every level or seek to do it, but many of us do. And so on that note, I just wanted to give like a little taste of the social work profession. So this is like the aperitif before the 5-course meal. So I'm going to hand it over. This was sort of like,
I'm sorry, I shouldn't have.
yeah, exactly. No, let's not go there.
My bad.
Yeah, speaking of people with lived experience with ADHD. That being said, I gave you a little sort of intro. I'm going to hand it over to Ledge Counsel, right, to do a walkthrough, and then we will hear from multiple social workers who will get more into the details of the benefits of this particular bill and in terms of expanding the social work practice I talked about across state lines.
Great.
So.
Wonderful. Thank you, Brian. Katie.
Good afternoon.
Good afternoon.
Katie McDonough, House of Legislative Counsel, and I put my document.
Okay.
So, at this point, I know this committee, every member is an expert on interstate compact. So, I won't spend a lot of time telling you what an interstate compact is. You're familiar with it from your work last year. So like last year, what I've done is I've taken the bill itself. I think in this case it runs about 50 pages, and I've tried to summarize it down to 5 pages. It's a dense 5 pages, but I'll walk you through the section by section summary, and if we have any questions, we'll go from there. So the first section we have is just acknowledging that by enacting this particular piece of legislation that you're entering into an interstate compact, and it's the social work licensure compact. So the first section, 3214, is just an acknowledgement of a formal adoption of entering into the compact. Section 3215 lists the purposes of the compact. I haven't listed them all, but it specifies to facilitate interstate practice of regulated social workers by improving public access to social work services, reducing duplicative requirements associated with holding multiple licenses, promoting mobility and addressing workforce shortages, and allowing for the use of telehealth to facilitate increased access to regulated social work services. And then we have a definition section. There are a number of defined terms, but I didn't mark those out on my, looking for my pen, on my section by section summary. And then we have the state participation in the compact itself. So to be eligible for compact participation, a potential member state has to license and regulate social work as either clinical, master's, or bachelor's categories, require applicants for licensure to graduate from a program meeting certain criteria, require applicants for clinical licensure to complete a period of supervised practice, and have a mechanism for receiving, investigating, and adjudicating complaints about licensees. And then to maintain membership, the member state needs to require applicants for a multi-state license to pass a qualifying national exam for the corresponding category of multi-state license that's being sought, participate in the commission's data system, notify the commission of any adverse action or the availability of current significant investigative information regarding a license, implement procedures for considering criminal history of multi-state license applicants, comply with the commission test, require an applicant to obtain or retain a license in the home state and meet the home state's qualifications for licensure or renewal of license. Authorize a licensee holding a multi-state license in any member state to practice in accordance with the compact and commission terms, and designate a delegate to participate at commission meetings. So similar to the other structures of other compacts we've looked at, a commission is formed, which is sort of the regulating body for the compact, and each state that's a member state sends a delegate to sit on the commission. Let's see. The member state must designate the categories of social work licensure that are eligible for issuance of a multi-state license. And probably more importantly to the committee across the hall, the home state may charge a fee for granting the multi-state license. And section 3218 has to do with the social worker participation in the compact versus the member state. So to be eligible for a multi-state license, the application, regardless of the categories, clinical, master's, bachelor's, must hold or be eligible for an active unencumbered home state license, pay applicable fees, including, as I said, any state fee that might be included, submit fingerprints or other biometric data, notify the home state of any adverse action, encumbrance, or restriction on professional license taken by any member or non-member state within 30 days of the action, meet continuing competence requirements established by the home state, abide by the laws and regulations where the client is located at the time the care is rendered. An applicant for the clinical category must fulfill one of the following competency requirements. So have a passage of a clinical category qualifying national exam, or be the applicant licensure in the applicant's home state at the clinical category, beginning prior to the national exam requirement in the home state, or the substantial equivalency. Attain at least a master's degree in social work and fulfill a practice requirement of 3,000 hours, 2 years of clinical supervised practice or substantial equivalency. Then we have language for the master's category, the requirements, again, fulfill one of the competency requirements, the same thing, the passage of the national exam or whatever was required in the home state prior to the national state exam requirement in the home state, or the substantial equivalency, and then attaining a master's degree in social work. The multi-state license for a regulated social worker is subject to the renewal requirements of the home state. A regulated social worker services in a remote state are subject to the member state's regulatory authority, including, in accordance with due process protections, removing the social worker multi-state authorization to practice in the remote state for a specific time, the imposition of fines, or any other necessary actions. If a multi-state license or authorization to practice is encumbered, the social worker's multi-state license or authorization is to be deactivated in all remote states until there is no longer an encumbrance. Okay, so section 3219, this is the actual issuance of the license. Upon receipt of the multi-state license application, the home state licensing authority is to determine the applicant's eligibility for the multi-state license. If eligible, then the home state issues the multi-state license, which authorizes the applicant, a regulated social worker, to practice in all member states under the multi-state authorization to practice. Upon licensure, the home state shall designate whether the regulated social worker holds a multi-state license in bachelor's, master's, or clinical category. And the multi-state license issued by a resident's home state shall be recognized by all compact member states under a multi-state authorization to practice corresponding to each category of licensure regulated in the member state. Section 3220 is the authority of the Interstate Compact Commission and member state licensing authorities. So the compact itself does not reduce the member state's ability to enact or enforce the laws and rules related to the practice of social work in the state, where the rules and laws aren't otherwise inconsistent with the compact. The compact doesn't impact the issuance or the discipline of an individual who holds a single state license or just to have a single state license option. The compact does not reduce the ability of a remote state to take adverse action against a licensee's multi-state authorization to practice in that state. And the compact does not reduce the ability of a licensed home state to take adverse action against a licensee's multi-state based on the information provided by a remote state. Section 3221 is the reissuance of the multi-state license by a new home state. So a licensee can hold the multi-state license in only one home member state at a time. And this section describes the process for licensees that change from one member state to another member state. It also describes what happens when a individual moves from a member state to a non-member state. And it specifies that the compact does not impact licensees' ability to hold multiple single state licenses at once. Section 3222 pertains to military families, and it enables a military member or spouse to retain one's home state designation while the military member is on active duty. In terms of adverse actions, 3223. The remote state has the authority to take adverse action against regulated social workers' multi-state authorization to practice only within that member state. Only a home state may take action on an individual's multi-state license. If adverse action is taken, the licensee's authorization to practice in all of the member states is deactivated until any encumbrances are removed. The home state shall give the same priority and effect to conduct reported from another member state when they're conducting an investigation. A member state may take adverse action based on factual findings of another member state, so long as it follows its own process for reviewing and taking disciplinary action. Member states may conduct joint investigations, and the compact does not authorize a member state to impose discipline against a regulated social worker holding a multi-state authorization to practice for lawful actions within another member state. Section 3224 is the establishment of the commission. As I already mentioned, the commission is the governing body to oversee the compact. The compact member states establish the commission, which comes into existence when the I should have said the effective date of the compact, not the commission. So when the compact becomes effective, that's when the commission is set up. Each member state is to have one delegate to the commission, and the commission is to meet at least once annually. And then we have a whole list of specific authorities of the commission. So the commission can establish the fiscal year of the commission, establish a code of conduct and conflict policies, establish and amend rules and bylaws, maintain financial records, initiate and conclude legal proceedings, maintain and certify records provided to member states, purchase and maintain insurance bonds, borrow, accept, or contract for services and personnel, conduct annual financial reviews, hire employees, elect or appoint officers, assess and collect fees, accept appropriate gifts, donations, grants of money, lease, purchase, retain, own, and hold property, sell, convey, mortgage property, establish a budget and make expenditures, borrow money, appoint committees, provide and receive information from law enforcement, establish an executive committee, and determine if the state's adopted language is materially different from the model compact language that's provided to potential member states. So those are all the duties of the commission. This section outlines the duties of the executive committee and describes the process for commission meetings. And then we have language about a data system. Like the other compacts we've looked at, the main governing body has a data system that collects all, retains the information about individuals holding a multi-state license. So the commission is to provide for the development, maintenance, and operation and utilization of this data system. It requires member states to submit a uniform data set to the data system on all individuals to whom the compact is applicable, including identifying information, licensure data, any adverse actions, non-confidential information related to alternative program participation, any denial of application for licensure, and the presence of current significant investigative information. But member states contributing information to the data system may designate information that may not be shared with the public without express permission. Expunge data, if data was expunged pursuant to either federal law or the law of the state that is contributing the information, so a particular member state, that would be removed from the database. Rulemaking. The commission can adopt rules for the implementation and administration of the compact. A rule has no effect where the majority of the member state legislatures rejects the rule or portion of the rule within 4 years of its adoption. Otherwise, it kind of becomes like it's part of the compact and it's binding on the member states. And this section describes the rulemaking process. Section 3227 has to do with oversight, dispute resolution, and enforcement. Executive and judicial branches of the member state enforce the compact. Judicial proceedings by or against the commission are brought in the jurisdiction that the commission is located. The commission provides notice of default to a member state that has defaulted on its obligations under the compact, provides process for state termination from the compact, dispute resolution, and legal enforcement. Section 3288, the effective date, withdrawing from the compact, and amendments. So the compact takes effect on the date on which the compact statute is enacted by a seventh member state. I took a look at the map before I came over, and it looks like while there's legislation pending in several states, the map showed that 1 or 2 states had enacted, I think 1. So were Vermont to enter, it wouldn't be an active compact yet. A member state may withdraw from the compact by repealing the enacting statute. So the same process they're going through now to enact it. It was repealed, it would have to go through both chambers and be voted on to exit participation in the compact. The compact does not invalidate or prevent a licensure agreement or cooperative agreement between a member state and a non-member state. It does not otherwise conflict with the compact. There's construction severability language that the compact would be construed liberally and provisions are severable, meaning if at one point one provision of the compact is deemed not constitutional, for example, then the rest of the compact would still stand. And then consistent effect in conflict with other state laws. A licensee that is providing services, social work services in a remote state under the multi-state authorization to practice has to adhere to the laws and regulations of that remote state where the person is providing care. So wherever the client is located, those are the laws of the state that the person has to comply with. So that was a great quick overview of us in a much longer bill.
So, and someone else might know this answer more completely than I do. But the reason that it's only been in 1 or 2 states is it's a brand new compact.
That's my understanding.
So it's not that states are having trouble getting it through, it's just that it's a brand new compact. So Brian had a question and then Art.
Yeah, we would be, I believe, a founding member if we made it, if we were one of the first 7. So I hadn't thought about this with other compacts till now, and I think it's because I'm a social worker. So like I was thinking about what this actually means for practice. But if the compact includes states with varying laws regarding reproductive rights, if a social worker in Vermont provides gender affirming healthcare, for example, to Vermonters, but a person in a member state, in that state, if it's illegal to provide that care, if the Vermont social worker provided that care to the person using telehealth, would they then be protected by our SHIELD laws or not?
That's a good question. I didn't work on the SHIELD law bill, so I'm not as conversational with it, but I know you spent a lot of time talking about it last year. And the compact specifies that you would, be required to be practicing under the state laws wherever your client is. Yeah.
And I think Lauren might be able to talk about it when she testifies.
Okay, we'll wait for that, but it just came to mind. I was like, thinking about the differences in laws, and that's one that popped up. And then here's one other quick question, and I think these are Katie questions and not other witnesses, but well, except maybe Lauren. But if a person gets, if a person lives in Vermont and Vermont is their home state, but then they move to New York and New York's not in the compact.
Gotta get your boots on.
Someone's unmuted. You might just want to know that. Did you hear that?
Yes.
Okay, yeah. I would want to be told before some catastrophic Zoom thing happens. It's been a while. If a person gets a home state license, let's say in Vermont, and then they move to New Hampshire, or no, to New York, and New York's not in the compact, is Vermont still considered their home state?
Not once they move. And there's there's language that I didn't spell out yet, but there's several provisions that talks about when a person in their home state moves to outside. I would say an exception, of course, is the military families. There's a provision that if, you have a home state and you're required to move because you're a military personnel or spouse of a military personnel, then you retain that home state.
If a person moved to, I'm using New York because it's one of those states that has had, a mixed, I think, history with the compacts, like some bigger states have. Like but let's use California to be a better example. Like if someone moves from Vermont to California, if California becomes their home state and they get a California license, but they still have a Vermont license that's an interstate license, can they still be practicing in the compact and California?
So only your home state can issue a multi-state license.
Okay.
So if you are Vermont or compact state is no longer your home state, I would assume that you couldn't hold a Vermont multi-state license if your home state is now outside of Vermont.
And is that the case for most compacts, or is that a unique feature of the social work one?
That's fairly standard.
Okay, so I want to also establish that this compact follows pretty standard guidelines of most of them.
I staffed one other compact last year. You've seen more than I have. But it followed the one that we looked at last year, that you passed last year, the mental health counselors. The structure is fairly similar.
So the challenges aren't unique to this one, but something we might want to consider in the long term around interstate commerce and, practicing across state lines.
Mm-hmm.
All right.
Art, and then Alan?
This language, Katie, is because this compact is just getting started, it sounds like, this social work compact.
It is just getting started, but what do you mean by this language?
Well, the language is established, right?
Yeah, so-
This isn't anything we are creating.
Correct. Whenever a compact is adopted, the entity that's trying to initiate the compact has model language. And every state, if they want to enter the compact, has to adopt language that's almost identical. That's why when we've done compacts in the past, we really don't make any changes.
Right.
Like the committees aren't really amending the compact language itself. It's sort of an up or down vote on the standard language.
So our language is the standard language?
Yes.
Okay. Because you said there was only one state signed up, I didn't know if there even was, I didn't know the status of.
Yes, there is, there's a website you can go to that talks about the compact, the model language is available there.
Okay, so, and the other question I had is, if we approve this, say with the second state, we have no idea when 7 states will approve.
That's
So
correct.
we might sit for a while without being able to institute this until that 7th state.
That's true. There is a map that shows that there's pending legislation in several other states, so I wouldn't guess how long it can be, but there are other states that
Witnesses who
are
might
moving.
be able to speak to more detail to that, though, like from this.
Who's that?
That we have additional witnesses after Katie from the National Association of Social Workers who could probably speak to. What the climate is nationally.
Yeah, okay.
Alan?
A question, I guess. We're going to establish a commission from one person from each state. So right now we've got 2. And then you look down at the powers of this commission: leasing property, purchasing property, borrowing, selling. That could come in effect as soon as you got 2 people in this.
No.
It would have to be 7 for the compact to be effective. A lot of these duties have to do with I guess what I'm envisioning is they need to rent headquarters, and they have to enter into a lease. So once there are 7 states that have statutorily adopted the compact, they each send a delegate to set up the commission, and then the commission is authorized to do these things.
And OPR can touch on that more as well. Great. Any other questions for Katie? Great, thank you, Katie. We appreciate you taking the time to put together the section by section. That I know it takes time and it's a huge help to us.
Oh, good, thank you.
It is a lot of work.
Yeah. All right, Laura Lane, then General Counsel of OPR is next, and welcome in person.
Thank you.
Thanks for coming.
All right.
I'm Lauren Lehman, General Counsel of the Office of Professional Regulation, for the record. Thanks for having me today. So the Social Work Compact, I was very happy to be part of the development committee that helped develop the model language. So the the Council on State Governments is an organization that the Department of Defense engaged to draft a lot of the compacts as an effort to facilitate military spouses and personnel being able to move between states. So there you'll see the CSG emblem on all of these compacts that come before you, and they're kind of the experts. We had Rick Masters last year, he's there. All these folks are the experts in compacts. And so when they start a compact, when they get the grant from the DoD, they engage state members to come in and provide technical assistance, guidance, background from state perspectives in developing the language. OPR in Vermont was lucky enough and happy to participate in the development of this compact. So we were there from the very beginning. It did get the language. There was a lot of back and forth. It's initially those 15 states, and then it gets all the state boards and all the state OPRs come and visit and discuss and meet and hash out the language and the models that they want to use. And so this process was finalized last year, which goes to the point that only one state so far has adopted it, Missouri. I think there are, I have it in my note in the testimony, but there are several other states that are currently considering it. And so there's, it's just a work in progress. 7 is the threshold to get started. Once those first 7 are on there, looks like 15 states are currently reviewing. So once once the commission started, the commission has the authority to charge fees, and they charge the state fees to participate. And through those fees, they then have to exercise the functions that are listed. They establish bylaws, they establish, governing rules based on all the states participating. All the delegates are the commission. And so then they use the commission funds to do things like purchase property, et cetera. That says that, it can trickle down because the state is paying that fee to the commission, and then the commission uses that to exercise its duties. So the Social Work Compact, OPR's position is similar to the other compacts. We support it. It's great policy, mobility, access, telehealth, helps for interstate disciplinary matters. The cost for this one's a little more significant than the other models you've looked at. The models that you've looked at, the last 4 compacts, are privilege models. This Social Work Compact is more akin to the Nurse Licensure Compact, where it is a multi-state licensure compact. This means that an applicant who wants to practice interstate, be part of the compact, goes through Vermont. We issue a multi-state license, and then they're allowed to practice anywhere in the compact without telling those states. The privilege model, you get a home state license, you go to the compact, say I want to purchase a privilege to work in Maine, Vermont, New Hampshire, you pay the state fee for Maine, Vermont, New Hampshire. And so this is a little different. Vermont wouldn't know who's working here, but we can always find that out. That's addressable. The fee structure, there's a cost of that licensing fee in the compact is distinct here. So when the licensee applies, so essentially the cost of the compact will be borne by Vermont licensees who want to be part of the compact through their multi-state licensure fee. In the privilege model, the fee is borne by out-of-state licensees who want to practice in Vermont in their state-specific fee. Here, it's Vermont licensees who want to practice out-of-state. They have to pay for the program through their multi-state license fee. So that's a little bit of a distinction here.
Can we just stop there? I want to make sure everyone.
So right, it's got privilege model versus compact model. Is that what you're-
Multi-state.
So it's privilege model versus multi-state. And the compact is in the privilege or the multi-state?
This one, the social work is multi-state.
Okay.
Any questions on that? Brian, and then Art.
Was I first?
Yes, you are.
Okay. So I wonder if it's the same question. So if I was a occupational therapist and that compact passes, I would pay a fee for each state I want to practice in addition to my Vermont license fee. But if we join the social work compact and I'm a social worker, I would get my Vermont license and then I would pay one additional fee, but that would give me access to as many states are in that compact. So at first it might only be 6, because there will be at least 6 before it goes into effect, but it could eventually be all 50 states for one fee. So does that have does it have a fiscal impact on Vermont, or is it just a difference you're pointing out to us?
It really depends on the uptake, and I think the difference is who bears that extra cost, right? So if you're saying that a Vermont licensee who wants to practice in New Hampshire, that Vermont licensee bears the cost of practicing in New Hampshire. New Hampshire doesn't have to pay for it. New Hampshire licensees don't have to pay for it. For the, in Vermont, what's happened is, for like the nursing licensure, is we had a significant number of out-of-state licensees who were buying full licenses here before. And now they're no longer buying licenses here, nor are they paying the privilege fee.
I see.
So now it's all borne by those in-state licensees who want the entire cost of administering the regulation of the program is borne by only Vermont residents rather than out of state. So really, I have some estimates, and there's Neil has been working on, or Nolan has been working on it with our data analyst on getting projections about costs. I put some estimates in the testimony today about, what the costs might be. But it always, we always have to see what happens in terms of who takes up the licensees, who doesn't take up the license, who pursues multi-state before we have exact numbers on the loss or the cost.
And again, this won't be an immediate revenue impact because we need 7 states in order to get it started.
Yes, and we would ask that it be an effective date out about 18 months.
Art, sorry.
I'm all set.
Daisy?
If you're, if we're one of those founding members that Brian referenced, do we have any special input as to the commission's founding bylaws and any other founding language in the compact?
Yes, we would be part of the founding bylaws. So that really gives us the opportunity to be part of that initial executive committee to set up the initial rules, set up the original structure of the commission. Eventually, everybody becomes a member of the commission for, the medical licensure compact, for nurse licensure compact, OPR. The state of Vermont is a commission delegate. We go to rules meetings. We have one vote, just like everybody else. So the benefit of adopting early is being in that original building stage. Eventually, everybody will be on the same platform.
But we don't have any input as to the compact language still, right? It's still what we're looking at right now. We won't have any ability to alter it.
Yeah, even the initial 7 on that compact commission won't be able to alter this. Once it gets to the stage that states are adopting it, it can't be altered because it's like signing a contract and changing the terms after one party signed it.
Okay, we have one more question.
Yeah, and I apologize if I can't, because I came in late. Just so I'm clear, you wouldn't have any idea who's actually practicing in the state. So you wouldn't have administrative burden unless they did something egregious.
We have an enforcement burden, which we experienced with the nurse licensure compact, where we still have to use enforcement and go through the due process and the disciplinary action and subpoenas, et cetera. But we don't have any revenue from that licensee. And we have to issue the multi-state license and build that program. So for this, I'll get to it in a minute, but there's several licenses I'd have to build.
Would you at least have access to a list of all people holding the multi-state compact license for social work, so that you may not know who's actually coming to Vermont via telehealth or in person to work, but you would know who all the potential people licensed doing that work could be?
In the nation?
Yeah.
Yes, in the full country. So, if we had a complaint against Sarah Smith, purely example, I'm sorry for all the Sarah Smiths, but if there were 7 Sarah Smiths, with a privilege compact, we could narrow it down to the Sarah Smith with a privileged practice in Vermont. Yeah. With this model, we would go to the compact and try to narrow it down based on birth date, maybe location of initial practice, et cetera. But there is that centralized database that the compact provides, which facilitates interstate discipline.
And it's the same process that's in place today for the nurses compact, which we've had for many years.
It's independent for each compact, has its own software, its own processes, but it's similar, yeah.
And then just one last thing, like, we were talking about how you wouldn't know who's practicing in Vermont, but I think, is it fair to say that we really don't know anyway, that there are sometimes people who practice illegally and we find out once there's a complaint?
Right.
Yeah, so I mean, that already happens. Like, there's people who work across state lines and no one knows they're doing it and they're getting away with it. So this would just, it just sounds like the main issue here is more that right now, maybe this is the main issue, but an issue that stands out to me is that right now you would know very clearly who's coming from out of state because they would get a license with us and they would be paying a fee for that license. And under this model, we'd have less of an idea of exactly who's using the license that way, and they would no longer be paying the fee because they're paying it to their home state. And we don't know necessarily what the fiscal impact would be yet. Would you say, though, that it might increase access to healthcare to have workers be able to more freely practice without these fees being a burden for them to practice here?
I would hope to say that. Yeah, I mean, I think we're all seeing kind of with the nursing and as compacts evolve and get established, we definitely see people being able to see their provider, go interstate, provide telehealth, access specialist care, which we're all very supportive of. It's hard to say if access improves with in-person because what goes out comes in, what comes in goes out, so licensees may no longer be here all the time. But our hope is always that care is, access is improved.
Okay.
Sorry, Lauren, we have another question.
I'm sorry, because I couldn't find it in the summary. Does the applicant need to reside in the home state? Okay, so it's not like somebody can just shop around for the cheapest
They
license?
need to reside there and they have to intend to be there for the long term, is I think.
Okay.
The definitions. So like to Brian's question, if you live in Vermont, Representative Gina's question, that you, if you resided in Vermont and you had a multi-state
License and you moved to California and that became your home state, you could be transitioned to a single state license in Vermont, but you could no longer retain your multi-state license. So folks from out of states who aren't members of the compact can't just purchase a Vermont license, a Vermont multi-state to get by that.
Okay, great, thank you, Lauren.
Of
course. So the other unique feature of this, again, I think more comparable to the nurse licensure compact is and also kind of the OT and PT, is there's different levels of licensure in this one, different categories. Vermont doesn't offer all three of the categories here, but we offer two of the three. So I think in Katie's section by section, she spoke about the clinical practice. So there's the licensed independent clinical social workers whose scope of practice includes psychotherapy and clinical care. That's one category of license. Vermont already offers those licenses. We offer the same requirements that are envisioned in the statute, or in the compact. So if a Vermont clinical social worker wanted a compact license, they'd need to pass a qualifying exam. They'd need to go to have an accredited social work degree, and they would need to have done 3,000 hours of supervised practice post-degree, after the degree. The other level of licensure that Vermont has is a licensed master's social work license, and that's also available through the compact. That license does not enable somebody to practice psychotherapy or clinically, but they can work on those other levels that Representative Chena described, that macro level and the group level. And they can call themselves a licensed master's social worker. So that's that qualification. Again, we have those qualifications in place to fulfill the compact requirements. We have the master's degree from an accredited institution and having passed the master's qualifying exam. So it's clinical qualifying exam, master's qualifying exam. The level Vermont does not have is the bachelor's level license. 16 states have a bachelor's level social work license, and it allows folks with a bachelor's level social work degree who have passed the bachelor's level exam to have a bachelor's level license. Vermont does not have that. that is a pathway in the compact to have a multi-state bachelor's level license. The compact would allow Vermont to grant that license, that multi-state license, even if we don't have an in-state bachelor's level license. That would be very complicated for OPR. So we would really want, if the desire is to move toward offering those bachelor's level multi-state license, we would want to talk about how to build that structure and that foundation in Vermont in addition to that multi-state layer.
So per the way the compact is written, we don't have to offer that. So could be a future conversation.
Kind of, yeah, like if we're going to do that. But what we are capable of doing, and we have the system set up for independent clinical social work and master's level social work.
Okay.
So we have both of those.
Okay, Lauren.
Maybe this is a question for one of the social workers, so it's okay if you want to wait for them. What is the difference in scope of practice between a licensed independent and a licensed person with a master's degree and a bachelor's? The masters, do they do like case management kind of work, but not independent psychotherapy, but independents can do psychotherapy?
I can only give you the technical legal explanation, which is the clinical can do psychotherapy and clinical work and the master's cannot. I don't know what the bachelor's level authorizes. It's in other states, but I'm guessing.
We'll hold that question.
So consider yourselves asked.
They know the practical, actual answer rather than the legal answer.
Thank you.
Okay. I think Katie hit on another really key, nice factor in the compact, and what was great about being part of the technical group was we were able to speak about the SHIELD law and about this reciprocal discipline idea. This compact has that concept of if you have your home state license disciplined or revoked, you no longer have a multi-state authorization to practice elsewhere. But it also says if your activity is legal in the state where you're practicing, then you can't be prosecuted for it in your home state. So your home state can't prosecute you for engaging in gender affirming care in Vermont. However, if you're in Vermont and you practice gender affirming care in a state where it's illegal, you can still be held accountable in that state. You just can't be held accountable in
But
Vermont.
they can't revoke your Vermont license. Can they extradite you?
That's beyond.
Okay. Let's not go over there.
Texas.
So they offer more protections in the social work compact for that reciprocal discipline issue. And so that's helpful.
Great.
I think I've hit on all of the top points. You know, again, we're very supportive of the policy and the process. This would be pretty costly, so we would want to examine how that gets funded.
So a couple of comments. One, Nolan will be in on Tuesday to go over the fiscal notes with us for both this compact and the OT. Remember, that is just for our knowledge. That gets kicked over to the committee across the hall. You would want us to change the effective date on this one. It says July 1st, 2024.
July 1st, 2025 would be ideal. Same for the OT compact.
Okay. Any other questions for Lauren before we move on? Great, thank you. Thank you very much. All right, next we have Lynn Courier-Stanley. Thank you, Lynn. Executive Director, Vermont and New Hampshire chapters of the National Association of Social Workers. Welcome.
The opening.
Yeah, sorry.
So thanks for hearing my testimony. Yes. Lynn Courier-Stanley, I am a social worker. I am the Executive Director of the National Association of Social Workers Vermont chapter. I'm also the Executive Director for the New Hampshire chapter. I live in Pennacook, New Hampshire, thus I'm licensed in New Hampshire. And so I think you may have heard this before, seeing as you've gone through a lot of compacts, but one of the reasons why the U.S. Department of Defense funds the grants to write the model language is because military spouses are some of the most underemployed people in the workforce. So if you have a social worker who's licensed in one state, their spouse gets transferred to another base, they're not licensed in that state, and it takes sometimes months in order to get licensed. Thus, that social worker is not able to practice. And that has been the case for all of for the OTs, for the
All of them.
So that's why the U.S. Department of Defense funds or issues the grants for the writing of the model legislation. And ASW was at the table for that writing, as well as Lauren Lehman, and other, people from all over the state, ASWB, and took over a year to hammer this out. And I believe one of the primary reasons why it's a multi-state as opposed to privilege is because that's one less cost that is shifted to the social workers. Also, there is a matter of if all of a sudden your client is in Florida, having to go and in crisis, having to go through that, getting the privilege, paying the fee, going the paperwork, can sometimes defeat the purpose of crisis care. In a nutshell, what this allows licensed social worker, independent clinical social workers to do is be able to see clients either in person or via telehealth in states other than Vermont. During the pandemic, when the emergency orders kind of took down the barriers that, going across state lines, we saw a tremendous increase in access and accessibility. People who were unable to get mental health services before, either because of transportation, being able to take time off from work, any of that, there was much greater accessibility and access to mental health care. And the world did not collapse when somebody saw a client who, was suddenly in Ohio or someplace else and could not get back to Vermont. This compact not only benefits social workers, it also benefits clients. For the social worker, and you're going to hear from a number of social workers who are licensed in multiple states, and it is not only expensive, but keeping track of all of the various relicensure regulations is cumbersome. Fortunately for social workers, and one of the things that makes me feel pretty comfortable about this compact is that the requirements for social workers to become licensed in the first place are really quite similar across state lines. California is probably the outlier, but you need to go to a CSWE, Council on Social Work Education accredited program. You need to have 2 years of postgraduate clinical supervised practice, and you need to pass an exam. And right now it is the ASWB clinical exam. Every state has that as its core. For relicensure, if you hold a Maine, New Hampshire, and a Vermont license right now, not only is it the cost, but in Maine, you need to get 12 CEs in domestic violence. New Hampshire, you're going to need to get 6 CEs in ethics, as opposed to the 1.5 in Vermont, plus 3 CEs in suicide prevention, and the 1 cultural competency for Vermont. And keep track of who needs what. Oh, and by the way, in New Hampshire, you've got 40 hours every 2 years of peer consultation that you need to keep documented. You see where I'm going with this. And many social workers do this because that's where their clients are, right? And the benefit for clients is that continuity of care. The kid who's come to college in Vermont will get to, and is receiving mental health services, will be able to continue seeing their social worker. The snowbird who goes from Vermont to Florida or Arizona will be able to continue seeing their social worker while they are away. Somebody who's on a business trip, whatever it is, continuity of care is vital. And for agencies in Vermont, there's an absolute benefit. If a social worker from another state that's part of the compact comes to Vermont, and gets the job here, they're already covered. There isn't that lapse, and really it's about billing. That agency cannot start billing for those services provided by that social worker until they're licensed here. This would allow them a grace period to come from whatever state they've come from, start practicing here. Now this is their home state. They go through the process, but they can still provide services, and that agency can continue billing. Representative, your question about the difference between an LICSW and LMSW and a bachelor's level. The LMSW is somebody who has their master's degree, but they're not doing clinical work. They might be doing advocacy work. They might be doing community organizing. They might be doing research. They might be, I'm sorry?
Case management?
Probably not. They could be, but probably not. The LICSW, what the licensed independent clinical social worker can do that any other can't is around psychotherapy, differential diagnosis. Oh, you have ADHD as opposed to some other mental disorder. And often it's the top tier signature on a treatment plan, right? This person's going to do this, the client's going to do this, and whoever does the initial sign up. But our BSWs, and Vermont has 3 BSW programs, Champlain, Castleton, and UVM. BSWs.
What does that spell out?
Oh, I'm sorry, bachelor's social work, bachelor's level social worker. Those programs are also accredited by CSWE, the Council on Social Work Education, and they are legally able to call themselves social workers. That might be case management, supportive services, like a family support specialist. The reason why you'd want, and maybe at some point I'll advocate for it, but not today, is becoming a licensed social worker at the bachelor's level, is that agencies can bill third-party insurance. It comes down to money in so many ways.
Are they for masters? Can masters people be billed?
Oh, yeah.
Okay.
Well, an LICSW, those services can be billed to Medicaid, Medicare, private insurance.
The master's level only, not the LIs.
The LICSW, those services can be billed to third party. An LMSW, I don't believe so, because I believe that the social worker who would get their LMSW is just not doing clinical work.
Okay.
That's, if they were going to be doing clinical work, they would be going for their LICSW.
Thank you.
So, but a bachelor's level social worker who holds a license in those 16 states that have, they are able to, their agencies are able to bill for their services. So.
Questions?
Yeah.
I want to try to understand, and it's somewhat germane to this, but I want to understand why and how someone uses a social worker. In other words,
So Art, I'm sorry, can I stop you? Because we're going to hear from four other social workers. Not that I don't want you to answer, but I want to make sure we have time for everyone to talk.
Yeah.
And I think as part of their testimony, Art, they'll explain what they do, and then we can drill down more, if that's okay.
And if I can do surface level, social work is a very broad scope of practice that a social worker could do. there is a section of social workers that provide psychotherapy. They get their LICSW and they're providing psychotherapy either in private practice, small
Yeah.
group practice, or agencies.
Okay,
But social workers do lots of different things in various places.
thank you.
So, any other questions? Thank you
Thank you.
so much. We appreciate it. Great. So next we have Robin. Should have checked these names before I started. Robin Klein or Clean. Robin, are you there?
Hey, Lori, before we begin,
Yeah.
just back to Art's question, it would be cool if as part of each witness's testimony at some point to answer why would someone come to them? Because I think then you can hear maybe some of the diverse, so I just want to put that out there,
Sure. Robin, hi, welcome.
Hi.
If you could say your name and what you do, just for introductions for the record, and then begin your testimony. That'd be great.
Sure. So my name is Robin Klein, and I live in Highgate. I currently work in operations at a health insurance company out of Pennsylvania with their behavioral health department. To answer the earlier question, I started my postgraduate career at a transitional women's shelter doing case management. I spent a year working with patients at in the state hospital setting. And I spent about 10 years doing inpatient and outpatient case management in the pediatric and adult inpatient settings before transitioning to case management with an insurance company. So that's my short life history. Where's the year again?
Very impressive.
Esteemed representatives, thank you for allowing me to speak today. I was fortunate to marry my husband at the end of his Navy career, so I was not subject to relocations every 3 years. We also met while he was stationed in Virginia Beach. With the greater Hampton Roads area home to 16 military installations, civilian doctors not accepting TRICARE was the minority, if they existed at all. Because my husband retired, we are fortunate to have TRICARE and not rely on commercial coverage. But after my experience in Virginia, I didn't give a second thought to finding providers when we moved to Vermont. I realized how spoiled I was once I started searching, and now I consider myself lucky if I can find a medical provider within an hour. Finding behavioral health practitioners is a beast of its own. TRICARE partners with the online platforms Doctors on Demand and Telemind, but those providers fill up weeks in advance and the Vermont offerings are slim. Over a year, I've only been able to connect with 2 practitioners, neither of whom were a good match. And it took about 6 weeks between when I identified them and when I completed my first appointment. I attempted to utilize the TRICARE Find a Provider website and the platform Psychology Today, reaching out to over 36 clinicians licensed in Vermont. However, very few offered virtual appointments, a necessity when you live in Highgate, or they were not accepting new clients. Like many others, I cannot afford to pay out of pocket. I've now been in Vermont 18 months and I'm still searching for a counselor for myself. In addition to being a consumer of mental health services, I am a licensed at the master's level in social work in Virginia, Pennsylvania, and Vermont. While under clinical supervision, I see clients in all 3 states. My specialties include perinatal and postpartum mood disorders, infertility, and military life. I hope to pass the licensing exam this spring and want to be accessible to as many clients as possible. A friend and colleague based in Colorado spent nearly $1,000 to obtain licensure in just 3 states. She works 40 hours per week and her schedule is packed. She'd love to expand to more states, but cannot afford to do so. Joining the Social Work Compact would allow highly qualified practitioners nationwide to provide desperately needed services to Vermonters. Expanding virtual access would also free up availability of local providers whose services are critical to those who can only see providers in person. Finding the right clinician is like finding the right shoe. If it's not a good fit, you aren't going to make it very far. I love living here, and just as you have with nursing, I implore you to join the Social Work Compact to provide Vermonters the opportunity to improve their mental health and overall quality of life in this great state. Thank you.
Thank you, Robin. Any questions? Alan, come on.
No, no.
Hiking in your area?
But it's from my area.
No questions? Did that help a little bit, Art, with your question?
Well, yeah, I actually, your troubles with TRICARE were of great interest to me, which isn't really
Right.
part of what we're doing here necessarily, but that's of great interest to me because that's something we hear from military folks
Yeah.
here.
Right.
Yeah, that's a whole different.
Right, they just don't have access.
But to that note, like, maybe, Robin, you might have the answer, you might not, but like, would the interstate compact potentially increase access for people who have TRICARE to providers? Because any social worker who's a TRICARE provider in any of the compact states who holds a multi-state license could provide that service to the Vermonter.
Yeah.
Absolutely.
Okay.
And my understanding is that TRICARE does not provide the best reimbursement. And so there are limited providers contracted with TRICARE. So expanding would absolutely increase the volume.
Great, thank you. Thank you, Robin, for your, for coming and your stories and for the work you do with Vermonters. We appreciate it.
Thank you.
Heidi Peterson.
Any relation?
Hi, Heidi. Can you hear us?
I can. Are you able to hear me?
Yes, we can. So if you can state your name and your position for the record and then share your testimony.
So I'm a clinical social worker in Vermont. I've been practicing in Vermont since 1989 and licensed since 1992. I began my postgraduate practice in an inpatient unit at the Brattleboro Retreat, and then later transitioned after I had my license to the outpatient program at the Brattleboro Retreat. I'm still a member of the staff there. And for the last 8 years, I have also had a private practice in Bennington. So I live and practice and I live in Bennington County. So I practice in 2 border communities so in Brattleboro, I see people from Vermont, New Hampshire, and Massachusetts, and sometimes even people from New York State. In Bennington is actually a hub for healthcare. So a lot of people on the New York State side of the border actually consider Bennington their place to go for services. And many people from Northern Berkshire in Massachusetts go there as well. So when the pandemic hit, it was really quite an issue. Everything shut down in person. I was fortunate that the neighboring states offered temporary licenses, as have been mentioned before. New York State offered to, on an emergency basis, recognize anybody who was actively licensed elsewhere with a license in good standing. I think what happened with New York State is a good illustration of some of the jeopardy for clinicians and for clients. So they had a temporary order, and I'd been paying attention to what was going on with that temporary order. And they said when it was going to expire, and then they abruptly ended it prior to that expiration date, which meant I couldn't legally practice with clients in New York. And so all of a sudden I had to scramble because the pandemic conditions were still such that my office wasn't physically open. So part of that scrambling was having clients come across the border in their vehicles and either find cell service or Wi-Fi where they could meet with me from Vermont. And people have said to me, well, what if I just didn't tell you that I wasn't that I was in Vermont? What I have to say to that is, if you tell me that you're in Vermont and you are not, you're putting me at risk because I'm not licensed, currently in New York, and my malpractice insurance doesn't cover that either. So I'm asking you to be honest with me about that. So I think this has already really been covered. The issue of being licensed in multiple states, it's very expensive. It takes an enormous amount of time. So when those temporary licenses expired, I became licensed in New York, Massachusetts, and New Hampshire. So I now hold 4 licenses, having held 1 license for basically 28 years. Now I have 4. And I have to pay attention to the costs, the requirements that Lynn Stanley had mentioned, and the different, and who's for continuing education, there are different providers who are acknowledged by different states. So some states will say, yes, this provider meets our requirements. Other states will not. It's very complicated. I actually had to put together a spreadsheet for myself to track all this so I can know, have I met the requirements for the state, and when are those renewals due? Why is this still an issue? Because I think other people have spoken to this as well. So it's not just pandemic conditions that make it important to be able to do telehealth or practice elsewhere. There are also situations where my clients have moved. So I have clients who I was seeing in person who now live in Eastern Massachusetts, and actually Eastern New Hampshire as well. They're still able to see me because I'm licensed in those states. There are people I see in Northern Vermont, which would still be under my Vermont license, who are able to access my services and my specialty because of telehealth. Some of those are professionals who don't want to be seen by people in their community. They want to be seen outside, and I've seen that happen cross-state as well. So for me, one of the major issues in being able to have a compact is to simplify the process. Ideally, you know also that there's background checks. You have to have there's a lot of information that you have to pull together for applications, and they take a really long time, as has already been mentioned. My New York State license took me about 4 or 5 months to come through. Massachusetts, similarly complicated. It's a really difficult situation to try to pull all this information together for all these different states. In the pandemic, when it was really shut down, I also had people traveling to Arizona. They allow people from elsewhere who are dually licensed to practice there up to a certain number of days a year remotely. For California, I had somebody go there who really needed to maintain continuity of services. So I got a single case approval from the licensing board there to see that individual. I've had somebody move to Florida. So for Florida, they have a provision for a telehealth approval that I was able to do with them. In the compact allows a simplification of a lot of this. Ideally, I'd love to see that the laws were similar, so we weren't having to try to juggle all the different laws and regulations in different states. So I've gotten to understand the compact more clearly. I see that part isn't going to be addressed, but simplifying the licensure and being able to provide continuity of care to my patients is really important. For people who have not been able to find a clinician elsewhere, they've been able to access my services. And then I've also been able to maintain my livelihood, which is incredibly important. So being able to switch to telehealth and maintain what I expect now will be both telehealth and in-person services has been hugely important for, being able to support myself and my family. I have all of this in my written testimony and some of the things that other people said as well. But, if there are questions about my practice or the practical aspects, I'm happy to answer that also.
Great. Thank you so much, Heidi. Any questions from anyone? Great. Thank you so much, Heidi, for your time and your testimony. We appreciate it. All right, we have Angela Paoli. I hope I said that right.
Yep, that's right.
Hi.
Hello, so my name is Angela Paoli. I am a licensed clinical social worker and the current president of NASW Vermont. I started practicing in New York State. I worked at Rikers Island, providing mental health care to the prisoners for about 4 years before I moved here. And that was in 1998. Since that time, I worked for UVM Medical Center in one of their family practices for 21 years. And for the last, I think it's 4 now, I've been in private practice. So I have had like a gazillion years of experience with issues that the compact would help tremendously. So I'm just going to outline a few of those after I say thank you all for the work that you do.
Oh, thank you.
So many times, I mean, like some of the other social workers have mentioned, we work with students, high schoolers that then go to college. And this is a huge problem because we can't see them in other states unless we're licensed there. And, they go everywhere. So you just can't cover all of those bases. And I had one young woman who had heard, I mean, they're talking among themselves. They said, Angela, if I get in my car, doesn't that make it okay if I just sit in my car for telehealth sessions? And unfortunately, I had to tell her that wasn't. And a lot of them will not take the time to get someone new and start over. And they wait until they come home for breaks or summer vacation. And this applies, like someone else had already said, to snowbirds as well. I also have that telehealth license in Florida because it was easy to do. That's the reason why I have that. So I can see my snowbirds via telehealth. The issue of clients moving out of state, another big problem. I worked with a woman on some very serious issues for several years, and then her husband got a job in another state. I did everything possible to ensure that she had someone waiting for her in that state, but she reached out to me saying, please, can't we just have a few sessions for continuity of care? And I mean, I knew this compact was coming. So I'm like, no, I'm not going to break the rules. Let's hang on to this. But she was very disappointed, and so was I. And then here's another whole section that is kind of a niche. So Vermont is unique in that they were one of the first states that allowed surrogacy, the caring of a child for someone else. So I also did adoption work for many years. And so when the Vermont Surrogacy Network started practicing, opened an agency, and there's Northeastern Reproductive Medicine as well. So surrogates are generally in Vermont, but some of the intended parents can be from out of state. So pre-pandemic, we were all going to these offices. They were coming from all over the place to meet in the offices. But now, since the pandemic and telehealth, it's much easier to do by Zoom because a lot of these people have to travel great distances. So that has put a big kink in the work that I do. We have to contract out with somebody else in that state to do half the work, and then I do the other half of the work. And I just kind of wanted to give you an example, like a surrogate. I'll meet with a surrogate for, say, an hour and a half, and their partner. And then I meet with the intended parents for the same amount of time. And then we meet together and go over all the issues, because this is a big deal. This is an emotional journey. And to make sure that everyone is emotionally stable to handle it, and also on the same page as far as their beliefs and how they want the process to go, it's just really important. So that is a very gratifying piece of my work. So that, and there's egg donors, sperm donors, egg recipients, embryo recipients. The field of reproductive medicine is growing rapidly, and we are making families in many different ways. And it's really wonderful. And I would love to be able to do all that work. So anyway, those are just a few of the instances that I wanted to outline and give you a perspective. So I just want to thank you all for listening to me today, and hope that this passes quickly and we get those 7 states.
Thank you, Angela. We appreciate your time and the fact that we were the first state for surrogacy. I didn't realize that, so that's pretty exciting. Any questions for Angela? Very helpful to hear what everyone does. And this is our 6th compact, I think we're hearing. We did 4 last year. So don't think that our lack of questions are for lack of interest.
Also, as social workers, I'm sure you understand that this is Friday at 2:30.
Right.
So the social environment that we're in right now is sort of like it.
In our first week.
Yeah. But it's a nice way to end.
Yes, it is. So thank you very much, Angela. Rita Monroe?
Yeah, Rita Monroe. Sorry, it was my mic snafu earlier with my 4-year-old who is still.
We've long forgotten that. That was a long time ago.
We love kids on screen. So
It was more a warning because sometimes people don't know they're unmuted and we hear things that they don't want us to hear, so.
Yeah, it is not.
So I live in Middlebury, Vermont. My husband is a professor at the college, and we just love our community here. And I'll kind of do a little bit more reading my testimony, and for the question of what do social workers do, I am definitely on the end of, I talk about people's feelings all day. I'm the one-on-one private practice in a office with lots of houseplants kind of vibe. So today I'm advocating for the Social Work Compact, representing the perspective of a licensed clinical social worker in private practice in a college town. Approximately 1/3 of my clients are college students, and interestingly, none of these students are local to Vermont, meaning none of them were born or raised here. Let me paint a brief picture of the diverse challenges they face, and these stories have significant changes to protect their anonymity. Lily, a freshman who hails from Idaho, is navigating anxiety as a pre-med student, struggling with perfectionism and excessive worry. Home breaks bring conflicts with her brother, who is on the spectrum and has anger management challenges and sensory processing issues. Helping her stay regulated and centered as possible in her family system is a key part of our work together. Rebecca, a senior from Massachusetts, has a long-standing obsessive compulsive disorder diagnosis that is exacerbated during family breaks, where there are very few interruptions to compulsive behavior or intrusive thoughts. She recently lost a close acquaintance to a death on campus, and there have been 2 tragic deaths since, one on campus and another in a domestic violence incident. Abraham, a thriving sophomore from Philadelphia, faces the challenges of being a gay man at college, struggling to form healthy partnerships with peers and prospective partners, all the while feeling like an outsider here due to his sexuality. Imogen, a sophomore recovering from an eating disorder, is attending Middlebury from Seattle. She's one of the most diligent clients I've ever had the pleasure of working with, and is so responsible in keeping a whole team informed of her progress. She collaborates with me, the health center on campus, her pediatrician, and 2 therapists in her home state to maintain her recovery. Keeping our work consistent during travel and home breaks, especially food-centered holidays like Thanksgiving and Christmas, is essential to her treatment plan. I am passionate about the work I do with these students, often in their freshman year and seeing them through graduation or beyond. I appreciate the flexibility that telehealth sessions have brought to our field, but it's also underscored the significant challenge. The current regulations prevent me from providing telehealth services to my out-of-state clients while they are away, even though these sessions could offer invaluable support during critical times. Home breaks are an opportunity to strengthen our therapeutic relationships, gain insights into family systems, and understand the cultural dynamics at play. I urge the approval of the Social Work Compact, which would enhance the quality of care we can provide to students and transitional adults, regardless of their location. Thank you for your time, consideration, and thoughtfulness. I love being able to work.
Let's see the 4-year-old.
Oh, good timing.
There you go. That's great.
What was that?
And being part of the therapeutic community with all of my and sensory tools. And that's my testimony. Thank you so much.
Great, thank you. That was very helpful to walk through situations of clients that you have. I think that helps put a lot in perspective for us. So thank you. Any questions for Rita?
Rita, are you a licensed independent clinical social worker? Are you an LIC? Okay.
Yeah. And one of the reasons I became a social worker was because of the national accreditation, that in case my husband were to get tenure, which he got tenure this spring, so that's huge, that I could, if we needed to move to a different institution or academic environment, I could move between states. And the social compact, I think, would really enhance even more of the degree to become a social worker, a clinical social worker, just to allow that flexibility, like military partnerships or anything where there's a level of transition that's possible. The other side note I wanted to say is if a third of my clients are out of state, that means that every time there's a break, I lose a third of my income, so the continuity for me as a working mom, trying to navigate childcare is important for our finances.
And you had a question?
Yeah, Rita, how do patients typically come to you? You went through the kids who you are counseling. How do they come to you? Do they walk in the door and say, I need help with this, or are they referred from someone?
There's a couple ways. One is the counseling session, the counseling center on campus has a limit of how many sessions students can have at the campus. So they often refer out, and I'm on that list of people that are referred to. A lot of them, Mommy, I need help. Can you bring your iPad to me? A lot of them tell their friends about me. So a lot of it is word of mouth. I sometimes have a Psychology Today profile active where students can reach out to me. And then sometimes people know my husband and know that his wife is a therapist and ask my husband for my name. So there's like a variety of interesting ways. But a lot of it is that there's only so many sessions they can have on campus. So if they need long-term therapeutic relationships or support, they have to find someone in the community.
Thank you.
Thank you, Rita. We're going to let you help your child with whatever it is they need. We appreciate the work you do, and thanks for your testimony. All right, so that takes us through all the testimony. Like I said, we're going to look at some fiscal notes on Tuesday, and then a tentative vote, well, hopefully not tentative, committee discussion and vote for both of the compacts on Wednesday. But we have some time, so I don't know if anyone has thoughts or comments.
I just have a question about the process there. So if we voted both those, if they both get voted out Wednesday, when would they be on the floor?
They would go to the floor, but then they would immediately go to House Ways and Means.
So they wouldn't be on the House floor with us presenting till the following week.
Oh, well, we don't know when House and Ways and Means would take them up.
Oh, they could leave them up for weeks.
They could leave them up for weeks.
So like if people wanted to advocate for the passage of these bills, perhaps they might want to think about their strategy for advocating to Ways and Means.
Potentially, okay. Yes.
That's a good thing for social workers to know.
Yes. Thoughts or comments? No? Nope, that's okay. We appreciate what you are doing. So you can watch on YouTube, or one of us can bring you up to speed.
You can watch it on YouTube double speed if your brain works fast enough. I can.
Like of all the compacts, I think this is the best one yet. And frankly, I think this one will have the most impact, particularly around, of course. Just as somebody who has worked with, for instance, clinical social workers, they kind of do the heavy lifting of most counseling. And we have such a shortage right now. And I know that every single time one of their patients takes a trip to Florida, it's like, nope, can't see you. Or the ability for other states' providers to open up their Psychology Today profiles and say, I will see you in these states. It's great.
You know, the thing that strikes me with this is how easy this is compared to the occupational therapy in terms of the licensure.
Privilege versus the multi-state.
Yeah, and I don't quite understand, other than it lets the states know who's working in the state, why the other ones are
Lauren, I don't see any
difficult.
comments on why they would do one way. If you don't, that's
or even why this one ended up this way. That would be helpful.
Yeah.
Yeah, I think it's both the ease, the knowledge states want to have knowledge of who's in
their state practicing. Lauren Lehman, for the record, General Counsel for OPR. And I think also the cost, who bears that burden of the cost? Not all states have the funding model that OPR has, where licensees pay for OPR regulation. They have state funding, and so having multi-state license, they can put that burden on the state versus on the licensee as applied to the privilege model. It's on the licensee to pay for every single privilege they want for every single state. Multi-state, it's one fee. And so, depending on how the model and that fee is set, it can reduce that cost for the licensee. I'm curious, Lauren, if you seem to have been on several of these startup compacts, and so is it generally the same people from across the states that are part of the commission?
No, it's usually the same core team at the Council for State Governments.
Okay.
So, and usually OPR usually has similar staff just because of how our professional regulation is structured here. A lot of other states have independent professional boards, and so they'll have unique staff for each profession. But OPR is consistent, usually me or one of the other two attorneys, and they always have a sitting attorney who, and the models, et cetera, they can offer a package pretty much to each profession to say, how does this structure work for you?
Right. So can you take over? I'll be right back.
I'm going to ask a question.
And then
Lauren, if the social worker is in Vermont and is working with people from another state, when they charge for their services, do all the states have different rates?
That is, unfortunately, I don't know the answer to that.
But I heard, I heard you giggle back here.
Can you say who you are?
Yes, Lynn Courier Stanley, NASW Vermont. If it's private pay, then it's cash, right? But if you are accepting insurance for Medicare, you're fine, right? Because Medicare is federal. If it's Medicaid, that social worker will need to get paneled on whatever Medicaid at the state level. Same with private insurance. You need to get paneled on every insurance company that you want to receive money from. Does that make sense?
Yeah.
So some social workers are paneled on Medicare, Medicaid, and Cigna. They may decide to become paneled on Harvard Pilgrim, Blue Cross. I mean, it depends on where you want to get paneled, and then you need to do it in each state.
Okay.
Yeah.
So my next question is there any data that has been collected to show whether or not the person who's living in Vermont is doing less work in Vermont because another state, they can get more money by working in another state?
Lauren Lehman, for the record, OPR has not gathered that data. I'm not sure that the compacts have advanced enough yet to see if there's that kind of shopping.
Yeah. Okay. Because it just came to my mind, I thought of visiting traveling nurses. They sometimes make 4 times as much as they would working here in another state.
so hold on. So Heidi.
I would hate to see people, a compact hurt us in that way.
Heidi, did you want to say something?
I could speak to that also as a clinician. So there's, 2 aspects. One of the aspects is licensure. The other aspect is getting impaneled with particular insurance companies. And when you get impaneled, you're accepting their contract and their allowed amounts. So, and the allowed amounts differ between insurance companies and what they'll pay for the very same service. And if you're going to, because insurance companies are working in different states, you'd have to get empaneled with other insurance companies if they're not also working within your state. But if I have a client who is a Blue Cross Blue Shield client, for example, it doesn't matter whether they are seeing me from New Hampshire or New York or Vermont or Massachusetts, I'm going to get the same rate regardless. So, I can't really cherry pick that way. I can cherry pick by which insurance companies I'm willing to work with, and some underpay, and I don't have an interest in getting empaneled with them. Some who pay more reasonably, I will be empaneled with. But I can't imagine going across the whole country at this point and getting empaneled with lots of additional insurance companies. So that's one self-limiting aspect in terms of people not just wanting to get the multi-state license and then, see clients largely from elsewhere.
Thank you, Heidi. Brian, and then I know you had a question, but I think you're answering this question.
It's an answer, and just yes, it's sort of an answer. Yeah, that an example I would give is like that. I have had clients who I'm working with them here, and their insurance is based here because that's where their family lives. But then they go to college, and I can't see them because they're in another state. But when they come home, I can see them again because I'm covered by their insurance, but I can't practice in that state. If they were in a compact state, I wouldn't have to get impaneled in the insurance. I'm already impaneled because their home insurance would cover them while they were there, while they're in college. And I think the question is like, then does that kid even find someone out there if that insurance is something people in that area don't have? So it allows continuity of care in that way. And I think that the labor of getting involved in getting impaneled in all these little insurance companies that are not regional ones, I don't know if people would bother. Like they would do that to compete. They would probably only do it to serve a person, an individual. Like I would go through that to serve a person I have a relationship with, not to kind of compete in a market in another state because we're busy enough. And then back to the question about tracking people working in other states. It's sort of like a question for the future. I just renewed my license, and I just want to say this was the easiest it's ever been. So thank you to OPR. Like it was the easiest it's ever been online, was like renewing my license. But there was a new piece that delayed things, which was a workforce census. But it was not a bad thing. It was actually cool to do because I'm like, this is the stuff our committee asks about. They're collecting this data. And it was asking about where we practice and different kinds of detail. And so we could always ask OPR to like integrate in to the workforce census ways to collect that information so we could track it. Because there's already like a system in place when people get licensed. I don't know what your thoughts are about maybe asking some more questions down the road in that census.
Lauren Lehman, for the record, we do gather data of where people's home address is, so we can say, you'll see the projections from Nolan reflect, the low level or just those folks from Missouri who are licensed in Vermont. That's who we will lose. We estimate will be passes. So that we do have that data, but in terms of tracking, down the line, use that function as well.
Leslie? I was just wondering if there are any other compacts coming down the road?
Lauren Lehman again, for the record, I don't. I think this is the last one for right now. Dental Compact has some discussion. There are two I'm aware of at this time, so that still has some work to be done. We need two dental compacts. But that's the only one I'm aware of right now that affects OPR.
And then we have the physician's assistant, which does not affect OPR. That is on our wall.
That's a medical study.
That we will take up at some point, yes.
Okay, great.
Yep. Okay, great.
Staring at our wall.
So if there's no other questions, just want to go quick back to thank you everyone for your testimony on this. It was fantastic. And we'll get back to it on Tuesday. And then just to recap from this morning with the testimony we had with House Corrections, which I thought was very interesting. It's going to be a process for us to work together to really look at all the layers of healthcare within our prison system. This is oversight that we're going to be working on. What's going to come out at the end, if anything, will be knowledge. Changes, who knows? We'll figure that out as we go. But we'll try and schedule some time for a debriefing. What I will ask is if you have questions from this morning that you want answered or data you want to see, from DOC or WellPath, please send me. I'm gonna put together a list and then I'm gonna send it to the woman Annie, and I forget her last name.
Ramiciano.
Worked with us today, and try to get some data for us before we have another joint session with corrections. So. And thanks for a good first week, and we can go off air.
Thank you.